And welcome to X-Ray Review. This is going to be the first of a series of radiology board case unknowns. So enjoy and good luck. And here's the first case. So some history on this individual. This is an 18-year-old male who presented with a progressively worsening left shoulder pain for approximately 2 months. And there was very obvious visible soft tissue swelling and asymmetry of the shoulders. And as you'll see, the left shoulder is visibly larger than the right. The doctor correctly ordered x-rays on this patient to include frontal and a modified oblique view. And let's take a closer look at the area in question. There is a large, aggressive-looking osseous lesion at the proximal humeral metaphysis, and it's hard to see where this lesion starts and where it stops. Very ill-defined borders, a large periosteal reaction extending to the medial aspect of the humerus as well, probable cortical destruction, and then again a lot of soft tissue swelling surrounding this osseous lesion. Here's a list of some of the characteristics of aggressive tumors on an X-ray. These include long zone of transition, ill-defined borders, cortical destruction, sunburst or spiculated periosteal reactions, Codman's triangle, soft tissue involvement or soft tissue mass, and then a clinical history of it being painful and growing, usually pretty quickly. And in this case, the majority of those aggressive characteristics are visible. So this should be considered an aggressive lesion until proven otherwise. And the appropriate follow-up would be advanced imaging to include an MRI or CT. MRI would be preferable, and then a medical consultation for evaluation and management. And this should be an immediate follow-up because again, we're assuming this is an aggressive lesion. So differential diagnoses for an individual of this age range, being 18, would include, and not limited to, osteomyelitis, Ewing sarcoma, osteosarcoma, aneurysmal bone cyst, or a blowout metastatic lesion. And after a medical evaluation, and this patient had a path-proven osteosarcoma. Osteosarcomas are primary malignant bone tumors of undifferentiated connective tissue, and they are the second most common primary bone tumor, accounting for approximately 20% of all primary bone tumors. Osteosarcomas can be classified into primary and secondary forms as well as histological types, of which conventional osteosarcoma is the most common. Approximately 75% of cases occur in young patients between 10 to 25 years of age, and then there's a 2-to-1 male predominance. And there are secondary osteosarcomas which occur in the elderly, usually secondary to malignant degeneration of Paget's disease or other various less likely conditions. From a recommendation perspective, the most important thing is that this patient has an immediate medical referral. Preferably oncological consultation, and this will be for the evaluation, treatment, and management of this lesion. Imaging of the chest is also important. Chest CT and bone scanning have a role in distant staging, and osteosarcomas have a known association with metastasis to the lungs, and specifically cannonball metastasis. So because of this high association, the lungs always need to be evaluated whenever an osteosarcoma is found. And to reiterate, anytime an osteosarcoma is discovered on an X-ray, advanced imaging such as MRI is going to play an important role of staging that lesion and also assessing any involvement of the adjacent soft tissues. When it comes to treatment and prognosis of an osteosarcoma, amputation or a limb salvage procedure is often the best option if surgically accessible, followed by chemotherapy. And the outcome varies greatly, with 5-year survival rate after adequate therapy at approximately 60 to 80%. Case number 2. And let's start with a little history. 68-year-old male presents to the chiropractor's office with progressively worsening shoulder pain, and the patient notices a visible soft tissue mass or swelling on their shoulder in comparison to the contralateral shoulder. And the patient complains that when his clothing rubs up against his shoulders, it causes an unexpected amount of pain. So given the patient's clinical presentation, a shoulder x-ray was taken, and here is a frontal view of the shoulder. And as you go through your search pattern, you will observe something is missing. And when we zoom in, you'll notice there is lytic destruction of the acromion. Only a faint amount of the cortices are even visible. I'll outline it here. And as we zoom back out, you should continue your assessment, looking around for other areas of skeletal involvement, assessing the area of lytic destruction. There seems to be some type of soft tissue mass which coincides with the patient's clinical presentation, but I don't see any obvious evidence of a periosteal reaction or, again, other areas of skeletal involvement. Some questionable areas of lucency in the proximal humerus, but otherwise, besides this lytic destruction of the acromion, that's all I see on this image. So based off the provided clinical information and this single x-ray, we know that this patient has an aggressive lytic lesion in the scapula, over the age of 60, male, and it's painful. So here's a list of differential diagnoses that I came up with. It's not extensive, but this does encompass a large amount of lesions that fit into this category. My recommendations at this point are to get the patient from the chiropractor to an immediate medical referral, as well as advanced imaging. Either MRI or CT would do the job, but I recommend MRI in order to fully evaluate the soft tissues. And this MRI was performed 3 days after the x-rays were taken, and this is a coronal T1. You'll notice a very large expansile osseous lesion arising from the scapula and extending into the adjacent soft tissues. And this axial T2 slice demonstrates the large heterogeneous mass, and again, much larger than I would have thought given the x-ray appearance. So if we go back to our list of differential diagnoses and think about all the information we've seen so far, being the clinical, x-ray, and MRI findings, this case ended up being a solitary plasmacytoma, and this was proven on biopsy. Alright, and to quickly review the solitary plasmacytoma, this is a tumor of neoplastic monoclonal plasma cells, usually arises in bone, although it can be in other extramedullary locations. The age of 40 to 80, median age of 55, more common in men, and then skeletal locations, usually the spine. Understand that plasmacytomas have an association with multiple myeloma. They may progress onwards to multiple myeloma, and if that does happen, it has a very poor prognosis. And usually with treatment, these are going to be excised, and then usually a combination of chemotherapy and radiation treatment. And here's case number 3. In this case is a 44-year-old female, and she presented with general low back pain. She noticed over the past few months general malaise and a decreased energy at work. Otherwise, there was no significant clinical history or any significant clinical red flags during the examination, and the doctor performed routine x-rays of the low back. Alright, and here's the frontal view of the lumbar spine. And I'll try to buy a little time for you to go through your search pattern and take a look for any significant abnormalities. And I'll zoom in to an area of concern that hopefully you spotted. And as we move down to the lower pelvis and proximal femurs, and if you take a look side by side, you should notice some significant asymmetries in the bone. And what we have here is an absence or lytic destruction of the inferior pubic rami extending into the ischial tuberosities and acetabulum as well. There's no obvious evidence of a periostral reaction. It's hard to exclude a soft tissue mass or soft tissue pathology just due to this being an X-ray. So this appears to be lytic destruction of the inferior pubic rami ischial tuberosity and extending into the acetabulum. And we'll zoom back out to review the lytic destruction in the inferior pubic rami, as well as look for other areas of skeletal involvement that we may have missed. And I don't see any other areas of involvement besides the ones we previously mentioned. So the recommendation for a patient with no previous history or clinical knowledge of this and no previous advanced imaging, this has to get moved on for further advanced imaging as well as a medical referral. So an oncological consultation is appropriate, as this is an aggressive lesion until proven otherwise, and then advanced imaging to include either MR or CT, probably both, and then bone scintigraphy to look for other areas of skeletal involvement. So the differential diagnoses for this lesion are not good. They're all going to be aggressive, and that includes Mets myeloma, lymphoma, different types of sarcomas, osteochondro, fibrosarcs, and then something like an osteomyelitis. All of these would be possible. So your best guess out of these, and hopefully that was the most common, which is lytic metastasis. Now all of these are technically possible, but lytic metastasis is statistically the most likely in a 44-year-old female. So a very brief review of lytic metastasis, as this is a huge topic, but it is the most common aggressive malignancy, which accounts for more than 70% of all malignant bone tumors. And there's different presentation, lytic, blastic, mixed, and blowout Mets, but lytic is going to be the more common, and there are lots of different causes for lytic metastasis, including breast, lung, thyroid, renal, bowel, and melanoma. And in this case, the patient had undiagnosed breast cancer, and that's what this ended up being, was lytic metastasis from a primary carcinoma of breast cancer. Case number 4. A little history on this patient. This is a 36-year-old female who presented to the office with occasional neck pain. She was recently involved in a motor vehicle accident, and the treating doctor took x-rays to rule out any trauma or significant abnormality. Alright, and let's start with a frontal view of the cervical spine. Now I'll give you a little time to go through your search pattern and look for any significant abnormalities, and then I'll provide you with a lateral view, which is much more revealing. And now with the addition of the lateral view, it's pretty clear that there is a large, well-defined geographic lesion overlying the occiput. And now, going back to look at the frontal view, we can see a large expansile density right around the patient's right ear. And now that we're zoomed in, you should be able to readily identify this density on the frontal and lateral views. So radiographically, I would describe this as a slightly expansile, homogeneous, mass-like density overlying the temporal or occipital region of the skull on that right side. And there's no evidence of a periostral reaction, no evidence of any adjacent soft tissue swelling or any aggressive radiographic findings. And now let's consider some differential diagnoses. And here we have blastic metastasis, Paget's disease, fibrous dysplasia, the benign osteoma, hyperostosis frontalis interna, a depressed bone fracture, or possibly an old treated bone tumor. And if any of these sound good to you, let's take a look. And the correct answer in this case is a benign osteoma. And let's do a quick review of a benign osteoma. So osteomas are going to be slow-growing, benign bony growths. Much more common in females than male, 3-to-1 female predominance, and they are almost found exclusively in the head and skull. They can be found in the mandible and face, but primarily going to be in the head and skull, the frontal sinus or calvarium. And typically these are asymptomatic. There's really no cause for concern unless these lesions are obstructing a sinus or so large that it's causing a cosmetic deformity. So normally there will not be any further recommendations or imaging on a patient with an osteoma. It's a leave me alone lesion, meaning no big deal. However, there may be an excision performed if there are direct symptoms related to the presence of that osteoma, like an obstructed sinus or a large cosmetic deformity. Case number 5. So some history on this patient. This is a 37-year-old female who presented to the chiropractor's office with mid-back pain of approximately 2 months duration. There was no significant mechanism of injury that she took note of, and occasionally she felt shortness of breath with any increased exertion. And here is a frontal view of the thoracic spine as taken at that initial visit. And I'll give you a little bit of time to look at this image and to assess for any pathology. And we'll zoom in a little bit to see the most significant finding on this image, which is substantial enlargement of the right mediastinum. So hopefully you saw this finding, and when we look side by side, it is very clear that the right hilar region is much more prominent than the left. And for a comparison, let's take a look at a normal thoracic view on the right. And if you look at the hilar regions of this normal image, they are not prominent, and this is how they should appear. But now going back to this case, this is definitely enlargement of the right hilar region of the chest. So some possible differential diagnoses to consider given the radiographic finding that we just saw, which was unilateral enlargement of the mediastinum. And some of these would include, not limited to, bronchogenic carcinoma, sarcoidosis, Hodgkin's lymphoma, tuberculosis, coccidioidomycosis, histoplasmosis, pulmonary embolism, or some type of atypical pneumonia. And this patient ended up having confirmed Hodgkin's lymphoma. So a quick review of Hodgkin's lymphoma. This is a common form of lymphoma, and there are 5 recognized histologic subtypes. With Hodgkin's lymphoma, there's a bimodal age presentation of a younger population group between 15 and 34 years of age, as well as an older population group of over 55. Usually, patients are going to present with general fatigue and a painless lymphadenopathy, kind of like in this case. And then don't forget, the disease is pathologically characterized by the presence of Reed-Sternberg cells. So based off of the finding on the chest x-ray, a CT scan of the chest was recommended, which confirmed the presence of the hilar mass. And then from there, biopsy. And the biopsy confirmed the Hodgkin's lymphoma diagnosis. And remember, there's different types, subtypes, and they have different prognoses, and then of course staging. So the earlier of detection, the better the prognosis. So there's a lot of things that factor into it, and these may lead to a combination of chemotherapy or localized radiation therapy, but an oncological consultation is going to be the most appropriate recommendation for this patient. Case number 6. This patient is a 74-year-old male who presented with lower back pain that has increased in frequency and duration over the past 6 months. And recently, the pain has increased and spread to the left hip. And this patient does have a history of cardiovascular disease and open heart surgery. A frontal view of the pelvis was submitted for interpretation. I'll give you a little bit of time to look this over. And now let's zoom in to the most pertinent radiographic findings on this image. And if we take a closer look at the left hemipelvis and compare it to the more normal right hemipelvis, you'll notice 3 major radiographic findings. First is cortical thickening, and this can be seen throughout the left hemipelvis, but if you look at the size of the cortices, they're larger on the left than they are on the right. Second is expansion of bone. The bone is slightly enlarged in this case in comparison to the normal right side. And then lastly is increased bone density. And there are many areas of increased density throughout the hemipelvis. However, I just highlighted this one region to take note of. And let's zoom out to take one last look at the pelvis before coming up with a differential diagnosis. And here's a list of differential diagnoses to consider in this case. We have blastic or mixed metastasis, Paget's disease, fibrous dysplasia, atypical osseous hemangioma, and osteoporosis. And this patient has confirmed Paget's disease. And Paget's disease is a common chronic bone disorder characterized by abnormal bone growth throughout the skeleton. It's usually seen in older Caucasian males. There are 3 different stages to Paget's disease: the lytic, blastic, and mixed. Typically on an x-ray, the blastic appearance is more commonly seen, which is what we saw in this case. And the classic triad of cortical thickening, expansion of bone, and increased bone density were also seen here. And there's a distinct absence of periosteal reaction seen with Paget's disease. So recommendations for this patient would be a medical consult for evaluation and management. There are many complications that can arise from Paget's disease, and these patients need to be medically managed. In order to confirm the diagnosis, laboratory analysis to include elevated serum alk-Phos or elevated urinary hydroxyproline can be helpful. And then for other areas of skeletal involvement, bone scintigraphy is a non-specific but very sensitive modality for finding those other areas of involvement. Case number 7. This case is a 5-year-old male who fell approximately 9 feet out of a tree. He landed awkwardly and now is experiencing severe pain on the left mid to lower rib cage, and only one frontal view was provided. And here is that one view of the thoracic spine. Now, most radiologists' pet peeves are rib injuries, and it's a very tough ask when you are only provided one view. So anytime you're concerned about a rib injury, multiple views are essential. A rib injury, rib pathology can easily hide on a single view. So again, multiple images of the area of concern are very important in ruling out pathology. So hopefully that bought you a little bit of time to look at this image, and I'll zoom into the area of primary concern. You should notice a linear area of increased density at the lateral aspect of the left lower lung field. This area of increased density is often referred to as an extrapleural sign, which may represent a soft tissue mass or underlying hematoma, and the area medial to this represents the lung field. And as we compare the ribs and look for symmetry, there is a small little bump seen at the inferior aspect of this rib, a small little density that's not really seen at any of the other ribs. Incidentally noted in the right upper lung field is an azygous lobe and fissure, but not of any clinical significance, but of note. And let's zoom back out to take one last look at the overall image. There's some postural changes, but otherwise, what is the most likely diagnosis for this patient? And that would be a rib fracture with a visible extrapleural sign at the lateral margin of the image, which suggests that the lesion is pleural or extrapleural in etiology rather than intrapulmonary. The most common benign cause for an extrapleural sign is a rib fracture. There's also this other area of increased density, which I don't think is the actual rib itself, but likely some type of hematoma or area of increased density adjacent to that fracture site. So the combination of these findings is pretty consistent with a rib fracture and adjacent extrapleural sign. So the recommendations for this patient are, like all fractures, a medical consultation for evaluation and management, as well as dedicated chest imaging. So at a minimum, a dedicated radiographic examination of the chest and ribs to better evaluate it rather than just this one view of the thoracic spine, and at best a CT of the chest to evaluate for any type of secondary complications like pleural effusion, etc. So this patient needs to be referred for a medical consult, and that is exactly what this was one fractured rib with an adjacent extrapleural sign and no pleural effusion. Case number 8. Some history on this patient. This is a 65-year-old male who presented to the chiropractor's office with chronic neck pain and decreased cervical range of motion. The patient also has a history of diabetes mellitus. And here is a lateral view of the patient's cervical spine. The frontal view was of little diagnostic value, so I excluded that. And we'll zoom in to the most pertinent radiographic finding here. And that would be the thick flowing hyperostosis noted within the expectant area of the anterior longitudinal ligament going all the way from C2 down to C7. It appears discontinuous in some areas and ankylosed in others. And as we zoom in a little closer, you'll notice a clear distinction between the vertebral end plates and the homogeneous density of that flowing hyperostosis of the anterior longitudinal ligament. So rather than degenerative osteophyte formation, this is hyperostosis or ossification of that anterior longitudinal ligament. As we zoom back out, you'll notice relative preservation of the intervertebral disc heights, as well as a lack of involvement of the facet articulations. These facet joints look relatively normal. And there's also no evidence of anything posterior to the vertebral bodies, such as ossification of the posterior longitudinal ligament. This is a separate case, but you can notice this homogeneous density posterior to C2, C3 and this is ossification of the posterior longitudinal ligament. Always something to look for, and it's commonly seen around the C2-3 or C5-6 regions. But again, I don't see that in this case. So some differential diagnoses for this case, and these are not limited to acquired osseous fusion, degenerative spondylosis, rheumatoid arthritis, diffuse idiopathic skeletal hyperostosis, ankylosing spondylitis, psoriatic arthritis, thyroid acropathy, and fluorosis. And the correct diagnosis is DISH, or diffuse idiopathic skeletal hyperostosis. And this is a very common condition characterized by ossification of the ALL and other tendinous and ligamentous insertions all around the spine. It's most commonly seen in the elderly, usually with a slightly male predominance. Patients with diabetes are also associated with DISH. Radiographically, you're going to see the combination of flowing ossification of the anterior longitudinal ligament of at least 3 or more contiguous segments, relative preservation of the intervertebral disc heights, and then a lack of sacroiliac or facet joint involvement, meaning there's no ankylosis of the SI or facet joints, which is commonly seen in other inflammatory or seronegative spondyloarthropathies such as ankylosing spondylitis. Recommendations for this patient are typically conservative care. It can be medically managed with analgesics and NSAIDs to reduce pain and symptoms, and there are potential complications such as acute fractures in the ankylosed segments, as well as things like dysphagia caused by mechanical compression from the adjacent ossification.
Case number 9.
A little history on this patient. This is a 48-year-old male who presented to the chiropractor's office with chronic neck pain and chronic lower back pain. And he was told years ago that he had some type of arthritis, but he couldn't remember what that was. Cervical and lumbar x-rays were obtained on this patient. We'll start with the cervical views, and I'll give you a second to look at these images and then zoom in to the major radiographic findings. The two most striking radiographic findings that I see are first the thin marginal syndesmophyte formation going all the way down the anterior aspect of the C2 down to C7 for vertebral bodies. And then second would be the clearly defined facet articulations. Usually you see the posterior facet joints very well, and these appear to be fused. So this looks like posterior element fusion. And then also the bone density looks a little bit decreased, and we have a hypolordosis with an anterior shift in head translation. And now let's take a look at the lumbar spine. We have frontal and lateral views, and I'll give you a few seconds to look at this before zooming into the key findings. An important radiographic finding in this case are poorly visualized sacroiliac articulations. Usually, the inferior aspect of the sacroiliac joints is clearly visible and delineated, and in this case, it's not well seen. So after reviewing the lumbar spine, some of the more important radiographic findings are again the bilateral sacroiliitis or possible ankylosis. There's no obvious evidence of posterior element fusion. There's the suggestion of early marginal syndesmophyte formation, and then the possibility of osteopenia. So taking all of that information into consideration, here's a list of possible differential diagnoses for this patient. And these are not limited to rheumatoid arthritis, diffuse idiopathic skeletal hyperostosis or DISH, degenerative disc disease, ankylosing spondylitis, enteropathic arthropathy, psoriatic arthritis, systemic lupus erythematosus, and gout. And this patient had a confirmed diagnosis of ankylosing spondylitis. And this is a seronegative spondyloarthropathy, which can cause fusion of all different areas of the spine and selected joints of the appendicular skeleton. It can also affect different areas like the chest and heart. Radiographically, there are a lot of very particular or characteristic radiographic findings that are seen with AS. And these are not limited to SI fusion, syndesmophyte formations, the shiny corner sign, Romanus lesion, Anderson lesion, dagger sign, bamboo spine, trolley track sign. You can get squaring of the vertebral bodies, posterior element fusion, secondary osteopenia, cardiomegaly, all kinds of things. So a lot of radiographic findings with AS. So recommendations for this patient is going to be a rheumatological consultation for evaluation and management. There are a lot of oral medications that do very well with ankylosing spondylitis. Laboratory analysis to include a CBC with an arthritis panel looking for the presence of seronegative factors can be very helpful. And then these patients also have a statistical probability of atlantoaxial instability due to that being a synovial joint. So any type of manipulation of the upper cervical spine, flexion extension views should be done to exclude any instability of that upper cervical region.
And thank you very much. I hope you enjoyed this. If you did, don't forget to like and subscribe. And if you have any questions, please put them below. Thanks again.